Hi, my name is Carrie Allen, and I am a pharmacist with Omnicare. I'm here to present to you today Medication Pass Fundamentals, Part 3 of our 3-part series. Just to give you a little background on how this presentation can be made really easy for you, if you want the downloads of the slides that have a lot more information than I'm actually going to talk about on them, what you can do is go right above the presentation. There's a little paperclip, and you just click on it, and a list of documents, specifically the slides, are there for you to click on, and you can print them out right from your computer. From time to time, we may add other resources or update things, so you can always check that to see if there's additional things for you to print out. The intended audience is really any facility or community setting that offers Medication Pass as part of their services. So it could be a skilled nursing facility, an assisted living facility or community, an MHMR facility. It's good for clinical and non-clinical management, so sure, your directors of nursing, assistant directors of nursing, regional nurse managers, but even administrators can get a lot out of this program. As someone who's been trained as an administrator, I know that we didn't get a lot of information on this type of thing, and it can be invaluable to know what's going on as an administrator at your facility, especially related to Medication Pass. Anybody who's involved directly in passing medication, so your nurses, your med aides or medication techs if they work in your state. Staff that may require an annual refresher, an occasional refresher, or even retraining secondary to a medication error. And any facility that's been permitted by their state governing body to use this training as part of a plan of correction. You'll find that I'm going to refer to the State Operations Manual and Skilled Nursing Facility regulations a lot, but just know that any of these processes I'm talking about are the minimum possible standards of care, and so they really apply to everyone and will help reduce medication errors in any setting. We're going to go through preparing and administering medications through the following routes in this particular presentation: enteral, inhaled into the lungs; topical, transdermal, subcutaneous, suppositories, and some common mishaps and errors that can occur along the way, as well as one slide on some key takeaway points from this entire 3-part series. We're going to go through these route-specific concerns that I mentioned, and I want to say again, I'm not going to read through every single point on these slides. There's a lot of great detailed information that's available to you on these slides, but there's also a lot of great information that's available to you through OmniView. We have policies and procedures that are available for nursing homes, for assisted living facilities, and sample medication administration policies and procedures. We also have additional training, and your pharmacy consultant can help you coordinate that additional training should you need it. This guidance to surveyors on enteral medication administration is important because before, it was sort of loosey-goosey. It sort of left it up to the facility as to whether or not they should flush after each medication. It was recommended, but it wasn't stated very clearly. Now, they're saying for administering medications by tube, the standard of practice is to administer each medication separately and flush the tubing between each medication. They do mention exceptions, you know, if there's a physician order that specifies a different flush schedule, or maybe an individual resident has a fluid restriction, that sort of thing. But in terms of counting medication errors and good practices, they're saying failure to flush before, in between, and after each medication administration is considered a medication error. So when you're preparing to put medications down a tube, the first thing you need to know is that you need an order to give medications down a tube. We'll go over later about how some medications that you can take by mouth you actually should never put down a tube. Make sure if you're giving oral medications that are in tablet form that you finely crush them. Make sure there's no chunks or little bits, and we went through that a little bit in the second video, so if you need to flip back to that second video to get a refresher, go ahead and do that. Again, prepare each medication to be given separately through the tube. So we're not going to cocktail, you know, when you mix all of them together in the little cup, unless you have an order to do otherwise by the physician. This is a point that I think people forget. You're in a rush, you're getting going, and you don't realize giving medications through the tube is fraught with pitfalls, both in technique, in process, clinically, and in infection control. So before you get in the room, make sure you have everything you need. You have multiple sets of gloves. You have a tray or other clean surface to carry all those little medications you've set up separately to administer. And plenty of paper towels. Paper towels will save you with infection control and tissues. I will want to say, though, that the tray can be a source of contamination, so what you don't want to do is just take it in and out indiscriminately. You want to wash it down first, and then when you are in the room and you're about to leave, you're going to wash it down again. You want to make sure, of course, the resident's in a private location and explain what you're going to be doing. Make sure that they're in the proper position. That syringe that you're putting into them to check placement and to administer the medications needs to have a proper date on it. And of course you want to wash your hands and put on gloves. If there's enteral feedings going, you don't want to give enteral feedings and medications at the same time, so you need to clamp that off. This is a good time to double check just before you're giving those medications that you're not giving medications that are going to interact with the enteral formula. So for example, when you're giving Dilantin, which is also known as phenytoin, it's a seizure medication and it tends to bind to a lot of things. So the tube fittings actually should be held about an hour before and an hour after the administration for that particular medication. For enteral administration, you want to make sure that you're checking tube placement in accordance with your facility's policies. You're going to flush with at least 30 milliliters of room temperature water prior to giving the first medication, or as orders dictate, of course. We prefer purified or distilled water to tap water, just because there can be issues with tap water having chemicals and those sort of things. You can flush with less orders if there are fluid restrictions. You can administer each medication separately because that's the best way to go to make sure that everything gets down the tube properly and things are absorbed. Ensure all the drug is emptied from those medication cups. Sometimes in the corners things get stuck, so you have to rinse them out, and you should be diluting things anyway. Allow the medications to flow down the medication syringe into the G-tube by gravity, so we're not pushing things through. After each individual medication is given, as I mentioned, 30 mils of room temperature water, or as orders dictate. Alternative volumes could be prescribed, but it needs to be specified in the orders for that resident. And even the state operations manual says that there may be cases where flushing with 30 mils after each single medication is going to overload someone with fluid or cause stress on their body functions. So you need to assess, individualize, go back and restructure orders as people need. At the end, the last dose, you're going to flush again with at least 30 mils of room temperature water, or as orders dictate. Restart that feeding, if applicable. Clean that medication syringe and return it to the proper storage area. Obviously, you're going to dispose of those gloves and wash those hands, readjust the head of the bed for the resident preferences, and move on. But I want to give you some pointers that not all people think about with regard to enteral medications. I think some people assume that anything that you take by mouth you can crush and put down the tube. And we all know that extended release preparations, those XLs, XRs, CD, ER, all of those things shouldn't go down a tube. But some immediate release preparations like sublingual tablets or even Prevacid Solutabs, it says Solutab right in the name of the drug. Those shouldn't go down the tube. Prevacid can clog the tube. Sublingual tablets can have such a profound effect on the resident that you may have to resuscitate them. At the bottom of the slide, there's a reference to the Journal of Parenteral and Enteral Nutrition, these ASPEN guidelines. And they have a story in there that's pretty significant, talking about a woman who just got a tube, and the facility went ahead and decided to give her regular immediate release medications. I think one of them was nifedipine, and her blood pressure dropped so low she actually had to be resuscitated. She was resuscitated, stabilized. The next day, they did the same thing because they assumed they could give these immediate release medications down the tube, and she died. So it's really important that you know what you can put down the tube. Check your do not crush list, check with the pharmacist, check with the physician, and make sure you have orders to give medications down the tube. On another point, if we're thinking about time management and accuracy, consider asking the physician for an alternative dose form when you have capsules that they want you to drain. So if you have one of those capsules with liquid in it and you have to pull it out with a syringe or you have to squeeze it, that's not as accurate, and it certainly takes a lot of time. In most cases, there's something else we can use. So talk to your pharmacist and the physician about that. You have to dilute both solid and liquid medications, especially potassium. And what this does is it increases the safety and absorption and decreases the risk for diarrhea and clogged tubing. Because you have to think about those liquids. A lot of the times they have things in them that help bind. There's suspensions, there's little particles. They have syrups and sweeteners, and that can help clog the tube. The last thing we need is a clogged tube. I also want to remind you not to push medications down the tube because we need to keep the air out of there. And you want to document and report any clogged tubes so we can figure out what's going on at the facility. If the tube is clogged, first you reposition the resident and the tube. Then maybe some warm water. Then more repositioning. Then maybe some gentle pressure and warm water. As a measure of last resort, there's something called enzymatic removal, and they sell lots of different preparations for this, but they're all expensive and they don't always work. An example would be if you used a pancreolipase tablet and some sodium bicarb. You mix them together, you mix them with water, and it works in the tube to help dissolve those things that are clogging it up. But again, it doesn't always work, and it's pretty expensive, and you require a physician's order for that. These home remedies, I guess you could call them, like cranberry juice or carbonated beverages like cola, seem like a good idea. You know, because cola supposedly can eat the rust off hubcaps, I'm not sure. But it's actually a bad idea. They can actually make things worse because they'll precipitate proteins out from formulas or different cations out from formulas that can further clog the tube. Anytime you see this little guy tripping over some common errors, this is a sign to you that it's a list of things that can trip you up in any process. So if you're flipping through and you need to just get a refresher on common errors, anytime you see this guy, that's the slide you want to read. So for enteral administration, failure to position the resident correctly is certainly a problem. Of course, failure to get all that medication out of the cup. So make sure you dilute everything. Swish it around. Dilute it some more if you need to. Get it out of the cup. Failure to flush after each medication. Failure to know fluid restrictions. I've been harping and harping on how much water you need to give, but some people don't need that much water, and it can be dangerous for them to have that, so you need to know. Don't give medications with enteral formula. A lot of times people think, okay, this is just a good idea, but there's so many interactions you can't predict that it's a bad idea. Failure to address medication timing issues. So you need to know when you need to hold feedings, when you need to time meds, and those kind of things. Failure to respect the resident's right to privacy. So usually this is twofold. You're closing the curtain and you're closing the door to the room. And obviously infection control. People sometimes forget gloves, forget to wash their hands. They forget to wash their hands after they've touched the bed sheets or repositioned the tubes. You know, your hands are now and your gloves are contaminated. Gloves aren't magic. The minute they touch something, they don't just get rid of all the germs. So you have to wash your hands and re-glove so that you're not contaminating things. Sometimes people will set the big syringe or other things on the blankets or other unclean surfaces, and then you've got contamination problems again. Our next topic is inhalers, and I've got pictures of Advair and metered dose inhalers like this one, and the Spiriva handy inhaler there, just to let you know that this applies to all of those and more. Something that people don't often remember is to bring a cup, an extra cup, for the resident to spit into after they use an inhaler, and we'll go over why on the next couple of slides. Of course, make sure someone's in a private location. Explain what you're going to do to them. Wash your hands, put on gloves. One of the things that people forget most often is you've got your inhaler and you open it up. You need to look in there there? Is there something going on in there? Did a little piece of the foil from the blister pack get in there? If you don't look and you go ahead and use it, there have been times when residents have choked and inhaled on just things that accidentally get in there when it's in the med cart. So make sure that you're doing that. If you're using a metered dose inhaler, you've got to shake it before you use it, and you may need to prime it. Just air shot before you use it if it hasn't been used in a while or it's been dropped, and your manufacturer will have information on that for you. Obviously, you're going to have the resident exhale and put the mouthpiece where it needs to be placed. I want to say, if you have a resident that is, they have so much trouble breathing that they get nervous, they can't quite coordinate when to inhale with a metered dose inhaler or one of those things, before you just jump to a nebulizer, because that's pretty time consuming, see if you can get the physician to try a spacer. I think spacers are really underused, and they're a really great way to get that resident to get all the medication in a very timely manner without having to use the entire nebulizer apparatus. So that's important to know. If, again, you're using a metered dose inhaler, just like the guy on the slide, make sure you're depressing it all the way down. It's not like on TV where you just kind of halfway do it, okay? Have the resident hold their breath per manufacturer's instructions, or as long as possible, because that's the rate limiting step. If they can't hold it that long, they can't hold it that long. And we want them to exhale slowly, because we need contact in there so that things work. If you have more than one puff that you're giving, whether it's the same medication or a different medication, you're going to wait maybe about a minute between puffs, or as ordered by the manufacturer or the physician. Now this is where your cup comes in handy. So you have an empty cup, and maybe you have extra water for the resident. And what they do is they gargle or rinse mouth after they're spraying. And what that'll do is, we're treating the lungs. We're not treating the mouth. So it'll stop the absorption through the oral mucosa, and it'll get that taste out of their mouth, and that'll make the whole thing more pleasant. One of the most important things to remember is if you're giving any medication, such as Advair, that has a steroid in it, if you leave that in the mouth, that can cause thrush. And I don't know if you've ever had thrush. It's very painful, so you don't want that to happen to people. So they take the water, they swish, and they spit it out. They don't swallow it. Got to remember to clean up all your stuff. This has been in people's mouths, so make sure that you rinse and dry the mouthpiece or wipe the mouthpiece of things that don't have removable mouthpieces. Dry them, you put them away. Of course, you properly dispose of your gloves and wash your hands. Nebulizers are very similar, but you might want to think about the facility policy for drug monitoring before and after treatment, because that can vary. Again, you're bringing in the empty cup for someone to spit into, and make sure you're assembling the unit per the manufacturer's directions. We have those little vials that, like Zopanex, albuterol, ipratropium, those kind of things, and those are measured pretty accurately, so you can just get in there and fill the reservoir. But if you don't happen to have those, you might need to use a syringe, or if you're using a different dose, to measure up that dose accurately so that you can fill the reservoir. You're going to use that handheld mouthpiece or the aerosol mask that goes over the mouth. And, just get started the way the orders say. Use the oxygen as needed or compressed air. The resident's supposed to breathe normally. And you are supposed to monitor throughout treatment. What happens is you leave the room, the resident kind of gets in their own thing, you come back, that nebulizer mask is up over their eye or up over their ear, and that's not the best way to get medication into your lungs. So we've fallen down there and making sure the resident is doing what they're supposed to do. So you got to monitor, all right? At the completion, of course, let the resident rinse and spit. And make sure that you're cleaning the apparatus in accordance with the device instructions. Some of those are kind of elaborate for the nebulizers, so follow through with that. Here's our tripping up guy. These are the common errors with inhalers and nebulizers. Using an expired product. Zopanex, again, great example. It's good for 14 days after you open the foil if you're keeping those little guys in the foil. If you're not keeping them in the foil, they're only good for 7 days. People date the foil and forget to look back to it, or they forget to date the foil at all, and then we have no idea when you opened it. It technically has to be assumed that it's expired. So these are just little things that sometimes you don't think about. Failure to have the resident wait between puffs. There should be about that minute. rinsing the mouth afterwards, cleaning the apparatus afterwards, failure to watch the resident while they're doing it, and of course infection control. And you're going to notice all the times I mention infection control as a problem because it's a big problem, and I think you guys could probably make some sort of gain out of how many times I mention infection control. But it's important for you to know. So forgetting gloves, hand washing, this is a big one. Taking that inhaler and just setting it down on an unclean surface. It goes in people's mouths, and you're touching things and bringing it in. It needs to be set on a clean surface, and it needs to be washed. Topicals. There's a bunch of stuff at the bottom of this slide that tells you about lotions and creams and ointments and powders and aerosol sprays. And that's all important, and you can read that at your leisure. I'm sure you know a lot about that already, but I just want to say a couple points about topicals. Importantly, have them in a private location. Okay? I've seen people give all sorts of funky treatments out in the hallway, just where everyone can see. That's not appropriate. Obviously, you're going to wash your hands, put on gloves, and make sure the skin is intact. Wash it, make sure it's dry, then you prepare your agent. And sometimes when you prepare your agent, you're not allowed to do it at the bedside. So you might have to do it at the cart and bring it in. Be prepared for that. You're going to apply it to the affected area, and if the doctor has ordered so, you're going to cover with a dressing. If not, you're not going to use a dressing. Dispose of those soiled supplies properly and wash those hands. Our tripping up guy, falling over the common errors, well, he says infection control. So forgetting the gloves, forgetting your hand washing, putting that product together and preparing it in an undesignated area. Failure to use a new tongue blade. So every time you go into, it's just like salsa. You don't double dip, put it in your mouth. You get a new tongue blade, you put the preparation where you're going to use it, get another tongue blade, put the preparation where you're going to use it. We're not contaminating here. Touching the applicator to an unclean surface, like the bed sheets or another part of the resident. And of course, privacy and dignity. Like I said, you don't want to be giving this out in the hallway. That's not appropriate. Transdermals. I'm going to go through this in a little more detail than you might expect because these actually have some very specific problems with them, and I'm trying to find my example of my transdermal patch here. So I have one. If you want to have the resident in a private location and explain the procedure, of course, wash your hands and put on gloves, and you're saying, why does she keep saying to put on gloves? I know this. Because I've had conversations with probably at least 15 nurses in the last couple years even, and more than that over the course of years, where, they have horror stories and I have horror stories where you forgot to put on your gloves, and these medications are meant to absorb through your skin. Lo and behold, they absorbed through their skin. I've had people with, the nitrogen paste. I've had people with fentanyl. All sorts of things can get into your skin, so you got to glove up. You're going to initial and date the patch before you put it on the resident. So you don't stick it on the resident and start writing all over them. You do it before. And you don't write on the portion of the patch, and the one on the screen you can see there's a specific portion of the patch that has the medication in it, and the rest of it's the border. That's where you write on it. This particular patch is an over-the-counter patch, and the whole thing has medication in it. So in that case, you lightly write around the edge as much as you can, but you still want to date and initial the patch before you put it on. Make sure you remove the old patch and clean the skin with wet gauze or even some alcohol if there's a lot of goo on there from the adhesive. That skin goes on intact, the patch goes on intact skin, and you rotate sites as recommended. If it becomes loosened, you can put that Tegaderm over it. You can use paper tape. Just follow the manufacturer's instructions. And remember that different patches have different application schedules, and different sites. So you have to check and make sure you're putting it on right, you're changing it at the right time. Fentanyl has very specific directions, and it's mainly because it's a class 2 narcotic. Okay? And the bullet in red says the remaining fentanyl in a used patch is a potential vehicle of abuse and accidental overdose and warrants implementation of adequate disposal policies. And that's a direct quote from a memo that guides surveyors, because we've had so many problems with this in skilled nursing facilities, assisted living facilities, independent living communities, in people's homes. You've got children and animals and demented people walking around these places, and sometimes they might just take a patch and put it on. I had a friend in a case where we were cleaning up a house with someone who had died of lung cancer, and he saw a patch, assumed since the person was dying of lung cancer that it was a nicotine patch, and he wanted to quit smoking, so he just took the patch, put it on. It was a fentanyl patch. You can die very easily if you are not accustomed to fentanyl. So I screamed at him, hey, you need to take that off right now. Disposal of fentanyl, and you're going to see some symbols right after the word disposal. That is not some sort of glitch. Those are showing you references at the bottom, because some of the stuff I'm going to say to you may be counterintuitive, and I want you to know I got it from a reputable source. When you dispose of fentanyl, and again, this is a class 2 narcotic, and there's going to be abuse issues that are potential, and you've got to protect people. You're going to fold the used or even the unused patch, if you're disposing of it, so that the adhesive side of the system adheres to itself, and then the system should be, believe it or not, flushed down the toilet immediately upon removal, if your state permits. Now, the manufacturer for the brand name Duragesic recommends that. It's on a list of drugs that should be flushed down the toilet by the FDA. CMS has some information that alludes to that, but you have to think that the EPA, the FDA, the DEA, your state agencies and municipalities have their own restrictions related to this. So if flushing is not permitted, you've got to find a way. Coordinate with the pharmacy, your local agencies, your facility. You have to dispose of it so that accidental access by staff, residents, and visitors doesn't happen, and it's also compliant with your federal and state regulations. Ideally, 2 nurses, 2 licensed nurses should witness this if you have that available in your facility. Destruction and associated documentation of unused Schedule II drugs, and this is a Schedule II drug, meaning that it's the most abusable class of drugs, should be completed per state and federal regulations and your facility policies. Now, common errors are trip-up die, failure to dispose of the product properly. And that's not just fentanyl. All patches, even this over-the-counter patch, if I were wearing it for the number of days or a whole day, would still have medication in it. And this one actually happens to have camphor in it, which is toxic to animals, in case you didn't know. So you're going to fold it, like I mentioned, so it's all stuck together, and then dispose of it in a place where no one can get to it. Failure to remove an old patch is a big one. You don't need 3, 4, 5 nicotine patches on a person. They're going to get pretty crazy if that happens. You don't need a bunch of estrogen patches, and you certainly don't need a bunch of fentanyl patches on people. So make sure that you're removing the old patch. Failure to date and initial the patch. We need to know exactly what happened, especially if there's 3, 4 on there. We need to know who left them on, who didn't change them, what's happening. Failure to change the patch on the correct schedule. And infection control, again, forgetting gloves, forgetting hand washing. We're going to go through subcutaneous injections because that's very common. However, I want to point out that we're not going to go through IV administration and IV intravenous preparation, because that's really, it's a whole other very in-depth set of teachings. So what we want you to do is contact Omnicare if your facility doesn't have their own teachings for this, and our wonderful nurse consultants will come out and they will do a great job of teaching you all about IVs. Now, obviously you want someone in a private location. You're going to explain the procedure. Please, as someone who's a healthcare consumer and you're someone who is administering something by needle, even if someone knows, explain the procedure. Warn them when you're going to do that. You've got to wash hands and put on gloves. I can't tell you how many times I've talked to nurses and they say, well, it's minimal blood, it's sub-Q, it's not a big deal. You are puncturing people's skin, there could be gloves, you need to protect yourself and you need to protect the resident. Okay? Make sure that you remember to rotate sites, and the only way you're going to know that you're rotating sites is if you look on the MAR to see where it was given previously. If you don't know because that person didn't document, you need to report that and we need to get a process going, all right? Make sure you clean that site with an antiseptic swab and go through your normal procedures of how you give subcutaneous injections. Very importantly, make sure that you're checking and pulling back on the plunger to make sure that there's no blood. So if there is, you use a different way to inject because we're doing sub-Q. We're not doing into the vessels. Now, some medications you are required to massage afterwards, but some you absolutely should not massage afterwards. And the most notable exception would be heparin, and that includes low molecular weight heparins like your Lovenox or your Fragmin, or even a medication called Arixtra. You're going to check that site for bleeding or bruising, dispose of everything the way that you're supposed to, and especially use a sharps container for those needles, and wash your hands. Some common errors that might trip you up with these subcutaneous injections are recapping needles. We shouldn't be doing that anymore. We should have safety needles where that's not necessary. Improper disposal of needles. I've seen people just throw them in the garbage. That's not appropriate. Sharps containers. Improper dosing, just drawing up the wrong dose. Those doses change a lot, especially if you have endocrinologists coming into the building. So make sure you're given the right dose. Like I mentioned, forgetting gloves or hand washing, super important. Insulin-specific concerns would be, are you mixing them correctly and are you allowed to mix them? So, remember your cloudy versus clear rules. And remember that you can never mix basal insulin, so your Levemir and your Lantus, with any other type of insulin. You just don't mix those. You give them separately. Holding basal insulin based on blood glucose readings, maybe in the normal or slightly low range, without a physician's order. Basal insulins don't work the same way. They don't work immediately. They're generally peakless and they work over a very long time. So it's not the same thing as when you're monitoring other blood glucose readings and worrying about other insulins, all right? That's a little bit different. Specific to insulin pens, which are very popular right now and are excellent and super easy to use, we do love those, is failure to prime the pen before each use. You actually have to waste a little, like a 2-unit air shot, to make sure that there's no air in that system. Sometimes people use needles more than once for these, and there's a couple reasons why you don't want to do that. Number one, it can get dull, and we've had cases where people use it and the needle actually breaks off inside the skin, and you don't want that to happen for sure. The other thing is that, and I've had nurses say this, oh, but it's a closed system. It's actually not a closed system. Some air can get up in there, blood can wash back in if you're reusing needles and those kind of things. So infection control is a big deal. We've actually had cases on the East Coast most commonly where you've heard of hepatitis C being spread because they were using the same insulin pen for multiple people, so you never do that. Failure to hold the button down, there's a little button on the end, for about 5 to 10 seconds, and it depends on the manufacturer how long you hold it. Some specify 6, some say 10, but the point is you need to hold it down to get all the insulin in. Generally speaking, holding that button down while you're giving insulin from an insulin pen should take longer than the time it takes you to give it via a syringe. Rectal suppositories, please, this should go without saying, but I'm going to say it anyway. Do it in a private location and explain the procedure. Do wash hands and put on gloves. And if you think I have watched a med pass where someone has failed to do this, you are right. I watched several. So as gross as that sounds, it needs to be said. You're going to think this is ridiculous, but we have so many stories about this. You've got to remove the suppository from the wrapper. It seems obvious, especially with these very sharp ones that I have looking on this slide. You've got to remove them from the wrapper. They're not going to work, and it's going to hurt the resident, okay? You have to make sure that you're discarding your gloves properly. You've been touching some very unclean areas, and that you're going to wash your hands afterwards. If the resident is having a laxative, make sure that they lay there on their side for about 20 minutes or so. It's because we want the maximum effect, okay? If you're going to have to go through all the trouble to help someone, relieve their constipation by using a suppository, yeah, you really want it to work. You don't want to have to do it a bunch of times. If it's some other medication, you know, they stay there for 5 minutes or so. Vaginal suppositories, you know, essentially the same thing, although the positioning is a little bit different. I did want to mention with creams and gels, you have an applicator for those, and they seem sort of flimsy sometimes. I mean, they're very effective, but what happens is people say, this seems a little flimsy, so obviously it's disposable, and they throw it away. And that's not true. You may have many applicators, and you can throw them away afterwards, but you may not. You may have one applicator that you're going to use for 7 days. So in that case, you're going to wash it and dry it, obviously, after every use. You know, it's got to be clean. And also, you want to make sure that you have it available for the next time. I've gotten several calls from the bedside, from nurses and from medication aides, saying, Carrie, I am here, and I don't know how to get this cream up into the area I need to get it into because we threw away the applicator. Do you have another one? And the thing is, pharmacy doesn't always have another one. So, you know, be sure that you're not throwing away stuff you shouldn't throw away, and wash stuff you're supposed to wash. Give people a sanitary pad because sometimes this stuff leaks out. And if you're only giving it once a day, try to give it at night because that would be the most comfortable option. Some common errors would be administering an expired product. Sometimes these are PRN orders. You don't use them that often, and we forget to check the dates. The other thing is half the time, and as I get older, this gets more and more frustrating to me, the date is the same color as the packaging, and it's on the crimping area in this little embossed text, and I'm just staring at it, trying to figure out what the expiration date is. But you have to check that. Improper storage of the suppository. Some of them have to be refrigerated, but not all of them have to be refrigerated. Obviously, forgetting gloves, hand washing, setting the applicator or the unwrapped suppository on the bed sheets happens. So, you know, bring your paper towels with you, all right? Make sure that you're not contaminating something that you're going to be inserting into someone. That's not the best way to go. This last slide is just a quick and easy slide that summarizes the key points in the medication pass process as a whole. So it summarizes all 3 of these different series that we've got. And I sort of made it look like a little medication cup just so it was cute. We're going to start at the top of the cup and go down to the bottom. So you want to be prepared and have minimal interruptions. And that should go without saying, but it unfortunately does not. And this means you individually need to be prepared, and you have to set up a culture for yourself that minimizes interruptions. But it also means the facility needs to get involved with this. They need to give you the methods to be prepared, and they have to have a culture in place that makes it so people do not interrupt you, because the more you're interrupted, the more likely you are to make a medication error, and there's lots of research on that. You want to apply time management skills. This is really time consuming. You want to apply your clinical and your technical expertise. Remember infection control, always, always. Remember to monitor, and remember to follow up. Respect your residents' rights and be compliant with HIPAA. And finally, document, document, documents. You need to demonstrate proper documentation so we understand what happened and we can follow things through, especially if something's gone wrong. This is a list of resources that were used in this presentation. And again, my name is Carrie Allen. I work for Omnicare, and we want you to know we are here for you to help you with anything you need, especially medication.